line of the work that I do in my lab has been focused on obesity and sugar addiction in particular. And so we've published a lot of studies showing that sugar, in fact, can be addictive. And we think that this is related to the obesity crisis. We've seen that sugar is a gateway to substance use. When it's consumed in excess, it can affect the dopamine system like a drug of abuse. It can affect the endogenous opioid system in the brain. This is why lollipops work to be good painkillers for kids at the pediatrician's office. And the AA Big Book recommends back in 1930 that sugar be used as a substitute for alcohol. Now, I certainly believe that ultra-processed foods is the primary component that's the vehicle for sugar consumption that's leading to obesity. I don't believe it is apples, yet both contain sugar. So I think there's parallels between that conversation that we are having today, in the sense that the primary substance of concern is not Kr8tom, but rather the concentrated synthetic 7-OH products.
Really?
These products are engineered to deliver opioid-like effects that can be significantly more potent than morphine. While 7-OH is present in dried natural Kr8tom, it is only apparent in, again, trace amounts, and again, as a byproduct of the drying process. So in treatment settings, this distinction really does matter. And as providers are seeing increasing encounters with patients who report using Kr8tom, but are in fact experiencing dependence on these concentrated synthetic 7-OH products. This misclassification has created challenges for diagnosis, for treatment, and it's also undermining public health data collection. And this is a key component to the conversation that we're having today. We have a way of preventing clinicians from actually treating the rapidly evolving threat. In response to this concern, my colleagues and I have recently published a paper about this in the scientific journal Substance Abuse and Rehabilitation, where we call for ERs to add to their intake forms to disclose whether or not people are consuming Kr8tom or they're consuming 7-OH when they come in and are in respiratory distress especially. The federal government has already recognized this distinction between Kr8tom and 7-OH. As we've heard, that the FDA has recommended that the DEA classify concentrated 7-OH as a Schedule I substance, citing its potential for abuse, addiction, and adverse health consequences. The FDA commissioner has made it clear that natural Kr8tom leaf is not the focus of this enforcement, and that their concern lies in the concentrated synthetic derivatives. We're not dealing with a single product category. I think that's clear now. We're dealing with two very different substances that are being treated as one. And if we fail to distinguish between them, we risk misguided policy, poor clinical outcomes, and continued public confusion. But if we act thoughtfully, we can target the real source of harm while preserving appropriate access and oversight. We don't want there to be unintentional harm caused by a blanket ban.
Thank you so much, Dr. Vida. And I would just say, for historical reference, the reason they wanted to substitute sugar for alcohol was because alcohol was illegal in 1930.